So thank you all for joining today's education session. It's a great pleasure to welcome Subarna Chakravorty, who some of you would have heard me say needs no introduction in West London, but for the benefit of those who are not from the area, Subarna is a consultant paediatric haematologist at King's College Hospital, prior to which she led the paediatric hemoglobinopathy programme at Imperial College Healthcare NHS Trust based at St Mary's Hospital, and having completed her training, specialist training in haematology and a PhD in the Centre for Haematology at Imperial College. Subarna's had many prominent roles within the hemoglobinopathy field in the UK, including one of the leads for the paediatric arm of the Hemoglobin Disorders Peer Review Programme, and currently chairs the NHS England London Region Hemoglobinopathies Forum, amongst many other activities. So it's a great pleasure, Subarna, to have you speak today, and we look forward to hearing what you are going to tell us. And if you're happy to take some questions afterwards, that would be great.
Thank you, Mark, for a very kind introduction, and thank you, Ralph, for asking me to come and talk in the West London Hemoglobinopathy Coordinating Centre education session. It's really, the pleasure is really mine. I was asked to talk about lung function and hydroxyurea in sickle cell disease. I must caveat that obviously I'm not a lung doctor, so today I'm not going to bore you with the intricacies of lung function in children, because firstly I don't know how, I'm not an expert in that, and secondly, I wouldn't know what to say in details. But what I will do today is kind of talk a little bit about acute chest syndrome, which is a kind of a boring, I guess not boring, but something which is there. We hear about it. We have to deal with it all the time, but we probably need to revisit what we do in acute chest syndrome a little bit, and just to appraise ourselves of what's out there, maybe. So I'll just try and cover chest syndrome a little bit, and then bring hydroxyurea in the picture, following on from how to prevent chest syndrome with what we have at the moment. So I will just share my screen now. So I was asked to do, as I said, a talk on sickle cell anemia, hydroxyurea, and lung disease, but I will go into more details via the acute chest syndrome route, if I may. So the pulmonary complications of sickle cell disease are many. So acute chest syndrome is perhaps, at least from a pediatric perspective, the most important of the pulmonary complications, but of course asthma is also very prevalent, as is nocturnal hypoxemia. The most of my talk is going to deal with acute chest syndrome and the use of hydroxyurea in overall preventing acute chest syndrome and improving overall lung function, etc. Pulmonary hypertension is more a kind of older patient with sickle cell disease condition, which we don't usually see in children. Pulmonary artery thrombosis is common, particularly with older patients, as is pulmonary fibrosis, but we will go into lung function and lung diseases a little bit more details later on. As in adults, both in adults and children, but particularly in children, there is a increased prevalence of reactive airways disease in sickle cell disease, increased tricuspid regurgitant jet velocity, outside of catheter-proven pulmonary hypertension, sleep disordered breathing, and nocturnal hypoxemia. So these are the kind of things that we would generally see in sickle cell. So lungs can be a major cause of morbidity in sickle. And you know, when I was at Mary's, we ran quite a good clinic with Professor Warner, with his interest in allergy and asthma and sickle. And of course, we do a clinic here at King's as well, and I'll show you some information that we have from our clinic as well. Sickle cell can affect every aspect of the lung anatomy, so be it vasculature, be it airway or parenchyma, and we will see fallout of all of those. I mean, obviously, it's due to abnormality in the blood vessels and the red blood cells, so it's literally everywhere. And often abnormal lung function is the earliest indicator of lung disease. And as soon as you can get a child to do a lung function test in sickle cell disease, you might start seeing abnormalities compared to healthy controls. There is a slight difference in the kind of disease that you might have on the pulmonary function test. So it might be more obstructive in children, more restrictive in older patients. And there are sort of proposals of various mechanistic things as to why that might be the case. And the in-between ages, such as adolescent as well as adults, tend to have restrictive or mixed obstructive restrictive disease. So work from King's College Hospital, London, it was shown that lung function worsens with age compared to health control. And this was a fairly long longitudinal study, a prospective study, where two groups of children were followed up for over 5 years. One group was a median age group of about 2 years of age, and the other was a median age group of about 10 years of age. And when they were followed for about 5 years, all aspects of lung function deteriorated with age, but children of around the 2 years age who had more acute chest syndrome, their lung function deteriorated even more than the older children. So that's something really big. This is pre-wide use of hydroxyurea data, so this is something really to bear in mind, that the drop or the worsening of lung function with age is particularly acute in sickle cell, much worse in younger people who might have more acute chest syndrome. And then a very similar kind of data was presented, again with patients from London who formed part of this sickle cell and asthma cohort. This study was conducted over a period of 9 years in the early 2000s, and where they showed that age is a predictor of small decrease in lung function. So if you look at lung function, age really stands out as the main predictor. This was a large cohort of nearly 200 children, a 4-year prospective study, and they all had at least 2 or 3 lung function tests during the course, among other things, lots of sleep studies, etc. as well. And that, showed that age is a very, very important factor, and perhaps the only factor in this study which associates with decrease in lung function. And when the SAC cohort, which is sleep and asthma cohort, which was the one that I've just shown you, when they compared it with adult cohorts, so this is the Vanderbilt cohort and the CSSCD cohort, these are old, larger cohorts of sickle cell, cooperative of sickle cell disease, and the Vanderbilt cohort. Sickle cell and asthma cohort was childhood cohorts. These are adults. And when they extrapolated the rate of decline in childhood on the SAC study, they were able to show that actually the rate of decline is much worse as you get older compared to what you would even predict based on what the young children were showing. So this is ongoing worsening of lung function. This is imputed data, of course, but just shows that this could happen if we don't do anything about it. So when we looked at it from from the King's cohort, there was a kind of proposal that there could be 3. There's a mixture. There's a number of different pathophysiologies happening within lung disease, in sickle cell disease, and broadly this could be divided into 3 clusters. So you have the first cluster. So this was based on a longitudinal follow-up study of more than 100 children with sickle cell disease, mostly young, up to their mid-20s. And the first cluster was basically moderate to severe anemia patients with increased pulmonary capillary blood volume, which had a mixed obstructive restrictive physiology. So essentially what happens is if you've got anemia, you've got a high blood volume pumping through your pulmonary vasculature, you have these large pulmonary capillary blood volume, which physically pushes onto or compresses the small airways extrinsically. So they're from the outside, these engorged blood vessels are compressing on the airways, causing obstruction. So that is particularly proven in case of pulmonary capillary blood volume of greater than 35 mL per liter. And then there is a second cluster of slightly older patients with restrictive lung disease and reduced DLCO, reduced diffusion capacity of less than, so the cutoff was at about less than 83% predicted to account for cluster 2, which was more restrictive. And then cluster 3 was the much younger patients, which were with baseline obstructive pattern in their lung disease, but showing bronchodilator reversibility and elevated serum LDH level, which might be suggestive of hemolysis. So there was an element of sort of inflammation associated with hemolysis in sickle cell disease over and above your standard hypereosinophilic atopic asthma in childhood. So, so these are kind of proposed sort of subgroups of lung disease as proposed by the King's group. So I'll go a little bit deeper into acute chest syndrome because this is obviously the common presentation in childhood that we see when it comes to lung disease. And I don't need to dwell on this, but essentially there is a fixed definition of pulmonary infiltrate of acute chest syndrome, which involves pulmonary infiltrate in a chest X-ray, which is new, associated with chest pain, fever, tachypnea, wheeze, and cough. But you will notice that there is no hypoxia in this definition, although all of us clinically always use hypoxia as an important definition for sickle cell acute chest syndrome, which is also, and this is just an X-ray, demonstrating a very significant consolidation in the left lower lobe in a very sick child with sickle cell disease, signifying acute chest syndrome. So hypoxemia is actually part of the BSH guidelines that came out in 2015. And what the guideline says, and you don't need to go into the details of this, I just put it out there. It's all there, free to download. But the main thrust of sort of acute chest syndrome management, has always been have a very low suspicion, low index of suspicion, because sometimes people can present with something which might lead on to a chest syndrome. Pulmonary embolism, fluid overload, opiate narcosis, hypoventilation can either trigger acute chest syndrome or worsen, or cause it, well, as in, worsen it. And that might require additional treatment on top of the treatment for acute chest syndrome, which is mostly supportive. Obviously, life-threatening, and I'll come on to sort of deaths associated with lung disease a bit later. And you obviously, in terms of sort of practicalities of management of acute chest syndrome, you really need to be on top of worsening hypoxia, increasing work of breathing, etc., to ensure that this patient is adequately supported. So this is very, very old data. So this is over 25 years old now, but essentially pre-hydroxyurea being widely used, a staggering number of people used to get chest syndrome. So for instance, under 10s, 25 per 100 patients per year. So, a quarter of your patients would get every year would be getting acute chest syndrome. So that's really, really huge. And if you look at the under 6 months, even under 6 months, you get 6.8 cases per 100 patient years, which is also very, very interesting. And that sort of will lead on to further work on this area. And then it could be as high as 30%. So 30 cases per 100 patient year at age 6. So that is, you can see how huge the problem was at one point. And as you can see in this picture, in this plot, you can see that the SS tend to do the worst compared to all the other genotypes of sickle cell disease. And this paper we are all familiar with, and I tend to go back to it from time to time just to remind myself what was said. And this was a really seminal paper published again more than 20 years ago. More than 500 patients with more than 600 episodes, 30 centers. It's one of those mammoth prospective interventional studies in sickle cell disease in acute chest syndrome, done in 30 centers in the US, which kind of really defined the was set the paradigm of management of sickle cell acute chest syndrome. And to be honest, I don't think we've gone any further forward 22 years hence in the management, but there might be some tweaks, and I'll come to that later. So in this study, and I've got a few slides, just a couple more slides about what this study came up with in terms of data. So nearly half of patients were initially admitted for another reason, mainly pain. So that kind of really embedded this understanding in management of acute chest syndrome, is that, be wary of acute chest syndrome happening in somebody who might not have presented with acute chest syndrome in the first place. So you do not want anyone languishing in a side, ward somewhere in the hospital with pain syndrome, but actually they've gone on to develop ACS, and that's something which is obviously we are constantly reminding ourselves not to do. And in this study, a staggering 13% required mechanical ventilation and 3% died. Not surprisingly, patients more than 20 years of age had a more severe course, and more than 10% had neurological events, and of these, half of those had a respiratory failure associated with acute chest syndrome, which was then led on to a neurological event. Treatment with phenotypically matched transfusion improved oxygenation, and that still happens to be the bedrock of treatment that we do for sickle cell disease. 20% of bronchodilator, 20% of patients who were given bronchodilators because of a history of bronchial hyperresponsiveness or asthma showed some improvement, and about more than 80% of patients who were put on a mechanical ventilator actually recovered. And where they did really go to town investigating the cause of what might have precipitated the acute chest syndrome, and a specific cause was identified in 38% of all episodes and 78% of episodes with complete data. So there still means that even if you go absolutely to town looking for causes, there'll still be 30% where you cannot really know. You will never find out why an acute chest syndrome event happened. Pulmonary fat embolism was a very important identifiable cause of acute chest syndrome in this study, and there were many infectious pathogens that were associated when a patient presented with acute chest syndrome. The most common cause of death was pulmonary embolism and infectious bronchopneumonia, and about half of the people who died of some form of infections. And I'm just showing this to you just really to show you the first two big ones on the top here. 71% of the 71 of the 249 infections, not percentage numbers, were chlamydia pneumoniae and mycoplasma pneumonia. So that kind of really set the standard of adding an intracellular bacteria cover when we treat patients with acute chest syndrome and making sure that infection is covered. So this was American data from about more than 20 years ago. And that we still continue to this day to give atypical pneumonia cover, mostly with macrolides. And then there was infarction, reduced oxygen level, increased hemoglobin polymerization, reduced in pulmonary oxygen levels, causing more vascular occlusion. So this is all kind of happening, all at the same time. This is pulmonary fat embolism. This is just a post-mortem picture of a patient who died of acute chest syndrome, and where you could see fat as well as bone marrow tissue within the bronchus of a post-mortem sample from a patient. And you can do bronchoscopic samples or sputum samples and stain them with fat stain and get it, which is what was done in the Vichinsky study from New England Journal, where you can do that. But of course, we don't do that. We just presume that some patients will have pulmonary fat embolism, and of course, it coincides with infection. And so, what the New England paper from that large study, the authors concluded was, although the catalyst of the syndrome may be pulmonary fat embolism, which is what they showed in majority of patients, or infection, these events precipitate sickling, regional hypoxemia, further ischemic damage, an environment which is ideal for sickle-related injury, and that is created by altering cellular adhesive molecules, damaging the vascular endothelium and stimulating cytokines. So this is really a very kind of comprehensive pathophysiological assessment of acute chest syndrome, which there's very little else, or there's only a few other things that have been added over the next 20 years in our understanding of what causes acute chest syndrome. So, anemia, hemolysis, inflammation, reperfusion, acute heart failure, both iatrogenic and otherwise, can cause, can precipitate or lead to acute chest syndrome. There's lots of different mechanisms happening, very complex pathology to kind of unravel. And as I said earlier, even with very, very extensive treatment, extensive investigations, 30% back in the day in that study didn't really have a precipitant cause. And this is just a picture to show you an acute neurological event that has happened as a result or associated with an acute chest syndrome. And I'll come to treatment. Now, treatment was supportive 25 years ago, is supportive today. You support with appropriate analgesia, adequate hydration, ensure not to overhydrate, physiotherapy, etc., transfusion, oxygen, antibiotics, bronchodilators if there is a history, and close clinical monitoring. So, I mean, there is really nothing else that we have been able to do or understand or learn or give in the context of sickle cell disease in the last 25 years. But some things have changed. What we now understand is a little bit more about more local, maybe the causes, that particularly viral etiologies and so on, or precipitating infectious etiologies that may lead to acute chest syndrome. So, for instance, in this study, which was in children, essentially all they did was they took a bunch of, they took 100 patients who presented to a French emergency department. These are all children, presented to a French emergency department with fever. And all they did was they analyzed the cause, the viral or any infectious cause of the fever, and followed up how many of these patients then went on to develop acute chest syndrome. And what they found was there is not really any statistical difference or any kind of difference between if you are infected with some pathogen that might give you more likelihood of acute chest syndrome or not. So you could be a patient A with influenza without acute chest syndrome, and patient B with influenza but with acute chest syndrome. So there is no particular virus that makes you more prone to developing acute chest syndrome. The other thing which is important to note is that in this 100 febrile children in France, and that's a more recent study, there were not a single patient with mycoplasma infection. So just really to try and think, are we, should we be thinking about universal mycoplasma treatment in children who come in with acute chest syndrome? And this was again replicated in adults, again a French study, and what they did was they simply just looked at, so that was the children's study was an emergency department study. The adult study is an ITU study, so the other end of the sort of disease spectrum, if you like. These were diagnosed patients with acute chest syndrome. When they looked at the bacteria and viruses that is found in these patients, the majority of them was Staphylococcus aureus, mostly susceptible to methicillin, one strep pneumoniae, other strep, moracella, etc. But there was, if you look at bacteriological, there was really no Legionella, and the respiratory multiplex PCR came up with some positive results, which were mostly virus. So there were again no mycoplasma in this study. And then just blood transfusion. Why do we give blood transfusion? Aim to correct anemia, reduce sickle cell percentage, and just really, I would like, and I'm saying this just because we need to bear in mind that if possible, simple additive transfusion is just as good as exchange transfusions. And it can be given readily. It can be given anywhere. And if you are suspecting that a patient's respiratory condition is worsening, I think it's much better to not rush off and arrange an exchange transfusion where you could, and which could take much longer, whereas you could just do a simple additive transfusion and that would kind of be enough. And this has been proven in so many observational studies where transfusion to a hemoglobin target of a certain pre-described hemoglobin target reduced the length of stay in children with ACS, and it really didn't make any difference whether you received an exchange transfusion or not. But of course, there are always going to be patients in which you have to exchange because their baseline hemoglobin is high. So increasingly with hydroxyurea use, you might find patients with hemoglobin of 95, 100 grams per liter, which you would find impossible to, top up. On top of that, there's such a high hemoglobin, and also other conditions that are associated with high hemoglobin, such as hemoglobin SC disease or S beta plus thalassemia. So in those cases, of course, you'll have to exchange transfuse. But I just want to remind people that you can always top up and see when that helps. Timing of the top up, I think, is important. And this is just a fun paper just to show. This is way back when, from the 80s. And this was a case series published from the Middle East in Saudi, where they just showed that, this blue line shows that a resolution of fever and other symptoms when there was very early initiation of top-up transfusion versus quite prolonged features of respiratory distress and fevers and so on, with resolution of vital signs, after blood transfusion was initiated. So I think there is some merit in early top-up transfusion if the hemoglobin allows. Non-invasive ventilatory support, increasingly using Optiflow, which is this high-flow nasal oxygen, which is warm and humidified oxygen given. Now, there are no direct studies in sickle cell disease, which kind of shows you, but we've simply kind of adopted it, extrapolating it from neonatal and bronchiolitis data and asthma data. There's a lot of work going on in intensive care in the UK about the understanding what Optiflow does in this situation, but we've kind of extrapolated that and using that in sickle cell disease to good effect. And steroids, some studies show that steroids can help, but if you give a lot of steroids and then withdraw it very quickly, then it might precipitate a rebound pain crisis, which might end up in a readmission episode. So be careful if you're giving steroids. Obviously, you need to withdraw it very slowly. Now we go on to prevention of acute chest syndrome in the acute setting. I mean, one of the very early randomized controlled trials set the paradigm of doing in-center spirometry. And this was published in the New England Journal of Medicine. It's people who were randomized, presented with pain, not acute chest syndrome, randomized to in-center spirometry. The rate of acute chest syndrome were lower in those who received the in-center spirometry intervention. We all know this device. And then prevention, I just brought this picture, this graph up, and this is from a very recent study from Africa showing the effectiveness of hydroxycarbamide or hydroxyurea in sickle cell disease. Although this is only using hydroxyurea, no other fancy new drug, in the context of Africa, it is new. There's new evidence emerging. Although this evidence is kind of 20, 30 years behind the evidence that has been gathered in America and Europe, nonetheless, it shows consistent and sustained improvement, reduction in acute chest syndrome episodes, even in the context of Africa. And this is a REACH study where 635 children under the age of 10 years in 4 sub-Saharan countries were tested. I'll come up to the MSH, the multi-center study, in a minute and a little bit more. So hydroxyurea and sickle cell disease. So induces the expression of hemoglobin F, among other things. We still entirely don't know down to the sort of last molecular mechanism exactly what causes this, but we know that it induces the expression of hemoglobin F in red cells. It improves the red cell hydration and deformability, and that lessens the rate of hemolysis, lowers the number of circulating white cells, which leads to increased endothelial inflammation, which, if there's loads of white cells, you would then will lead to decreased endothelial inflammation if you're able to remove those white cells and vaso-occlusion. It decreases the expression of adhesion receptors on the red cells and endothelial cells. Hopefully that will lead to reduced vaso-occlusion. And it releases the nitric oxide moiety that not only decreases platelets and coagulation activation, but also lessens endothelial injury through its vasodilatory effect. So there's lots of different things happening with hydroxyurea and lung and sickle cell disease overall. And hydroxyurea and acute chest syndrome. So in the MSH study, the multi-center hydroxyurea study, which was conducted, way back when in the 1990s, found that significantly fewer patients taking hydroxyurea developed acute chest syndrome. compared with patients who were treated with placebo. And remember, they used a very, very small dose back in the day, only 15 milligrams per kilogram. And even then, they found significant reduction in the rate of acute chest syndrome compared to placebo. And then when this was again trialed in the baby hug study, which was 300 asymptomatic babies between the ages of 9 and 18 months, they also found that although the primary endpoint of this study to do with splenic and renal function were not met, the secondary endpoints, one of the striking features was that it significantly reduced the rate of acute chest syndrome in those children who were randomized to receive hydroxyurea in asymptomatic babies in a fixed dosing of 20 milligrams per kilogram. And then a subset of baby hug trial analysis showed that the beneficial effect of hydroxyurea on ACS incidence was most pronounced in patients who had lower hemoglobin values. So the lowest quartile hemoglobin patients appeared to have been doing the best, had the best outcome. Again, fixed low dose treatment in asymptomatic babies. There's endless information about hydroxyurea's salutary effects on lung function. A recent publication from an American group, and this is the I think this is from Vanderbilt, showed that compared to, so this is basically showing that the annual decline of pulmonary function tests. So as we age, our rate of pulmonary function test declines, much more so, as I showed you earlier, in sickle cell disease. And when you give hydroxyurea to these patients, if you do a before and after analysis, and in this case, there were 56 patients who had pulmonary function test done before and after hydroxyurea, and there was significant improvement in FEV1, all kind of parameters, FEV1, FEV1, F2 FVC ratio, etc., forced the total lung capacity, all sorts of things were improved. And interestingly, the patients who are in control, this was kind of a retrospective thing almost, because they were just simply looking at sickle patients who were on hydroxyurea. They were kind of almost, although they were prospectively following these patients, I think this was a post hoc analysis of this. When they found that those were sickle patients who were not on hydroxyurea, their rate of decline was less pronounced or less improved, if you like, than those on hydroxyurea, which meant that people who were on hydroxyurea clearly were chosen because they had much worse disease. But this is sort of pre an era where almost everybody is recommended. And again, this is following on from the MSH study, so which is the multi-center hydroxyurea randomized control study, where there were very long-term follow-up. And this is basically showing mortality in patients on hydroxyurea. And if you look at this particular slide, you'll see that acute chest syndrome episodes on patients on hydroxyurea followed up over 9 years since the beginning of the randomization. They found that patients who had on hydroxyurea who had 1 or more episodes of acute chest syndrome had a higher mortality rate than people who had no chest syndrome due to the protection provided by hydroxyurea or otherwise. And when these same patients were followed up even longer, about 17 years on, and published in 2010, so this continued for 17 years, and as you can see, the rate of mortality events were the lowest in the patients who were on hydroxyurea for the longest time. So really showing that there is, undeniable improvement of longevity in patients with hydroxyurea associated with reduction in acute chest syndrome rates, among other things. So real-world evidence in Cincinnati Children's Hospital, Pat McGann, who was speaking in this very meeting a few weeks ago, their group. So when they started really increasing the uptake of hydroxycarbamide, so they had 2 cohorts where there were 43% in 2010, 43% of their cohort using hydroxyurea versus 95%, staggering, in 2019. And again, they were, obviously started much earlier in the latter period. And 97% of children born after 2013 received hydroxyurea. And the number of sickle cell related admissions significantly decreased in these two eras where there were more proactive, widespread use of hydroxyurea. So 67 per 100 patient years in 2010 versus 39 per 100 patient years in 2019, with a p-value that was significant. So really giving hydroxyurea, starting early, giving it to more and more asymptomatic patients, or maybe with very minimum symptoms, lowering the bar in which you start the hydroxyurea appears to reduce incidents that require admission to hospital. And this is again similar as we have seen in King's College Hospital, where kind of initiation of more widespread hydroxyurea has reduced the incidence of admissions. And looking at particularly lung function test with hydroxyurea in pediatric sickle cell disease, this was again King's data, where when they this was retrospective data for patients. If you look at the various aspects of lung function that were analyzed pre and post hydroxyurea, you'll find that the mean overnight SpO2 in 21 patients, 93 to 95, and this was about a year, I think, or 18 months pre and post. Overnight oxygen nadir, 84 to 87, 3% ODI. This is sleep, obstructive sleep apnea metric. Again, significant, well, not quite achieved significance. Daytime spot H2, SpO2, again, significantly reduced. Hemoglobin significantly improved. Fetal hemoglobin increased, and neutrophil count, there was not much difference. But this was kind of retrospective data, and again, slightly less. This is not maximum tolerated dose hydroxyurea. This was probably 15 to 20 milligram per kilogram type hydroxyurea treatment. But clearly, there's loads of different areas of lung function improved simply with hydroxyurea use. Again, this is just a kind of cartoon that proposes some ways in which hydroxyurea might be helping with general sort of availability of nitric oxide within the vasculature, both helping with endothelial disease as well as red cell hemolysis related damage. Again, as I said to you, and hydroxyurea is proposed to kind of intervene at this stage, increase the nitric oxide availability, and reduce vaso occlusion. Again, as I said, the exact pathophysiology has not yet, fully been dissected out. Lots and lots of people are still working on it. So other things for acute chest syndrome, as well as kind of general overall, I haven't gone into pulmonary function. I haven't gone into pulmonary hypertension or asthma treatment. I'm not a lung doctor or a cardiologist, so I kind of limited myself to acute chest syndrome management. And these are kind of new things. Again, as I said, nothing new really has come through. There was a secretory phospholipase A2 inhibitor, which was trialed a few years ago, but was terminated because there just wasn't enough recruitment. So I've not heard that this is happening, or any other drug company has taken this up. So in summary, hydroxyurea treatment results in reduction in incidence of acute chest syndrome. Hydroxyurea use is associated with increased longevity, improves multiple features of pulmonary function, as we've seen, drop in decline of lung function with time. Acute chest syndrome is multifactorial. 25 years on, treatment is still supportive. Avoiding acute chest syndrome by early use of hydroxyurea is advisable. And I'd like to end by acknowledging my colleagues at King's College Hospital, Dr. Atul Gupta, who's a pediatric respiratory medicine consultant, with whom we run our joint sickle cell lung function clinic, Dr. Sue Hite and Professor David Rees, who are my colleagues, pediatric hematology consultants, Sandra O'Driscoll, Saba Mahmood, and Hannah Harwood, who are our CNSs, and patients and their families. And I thank you for your attention. I would like to take some questions.
Thank you very much for that great overview, Subarna. Can I ask you to start, in the Wyszynski paper, there was a very striking difference in mortality between children and adults with acute chest syndrome. Are there any insights into what the mechanism of that might be? What explains that might suggest different therapeutic strategies?
I mean, one thing I can think of, I suppose, I guess among the multifactorial causes that precipitate acute chest syndrome, the thing that we probably don't see as much in children is to do with sort of pulmonary embolism. So I would imagine, and also I guess if you've got abnormal pulmonary function already at an adult, at an older age, the chances of you developing respiratory failure and then not recovering from supportive treatment is more likely, I guess, and obviously your baseline lung function is likely to be less good compared to children. So yeah, it's obviously likely to be multifactorial. And pulmonary fat embolism wasn't really that much seen in the children compared to that in the adults. I mean, even the children sputum expectoration, some children had in that study also bronchoalveolar lavage. So it was a very invasive way, but they didn't really find as much pulmonary fat embolism as they did in the adults. Again, that might imply that there is a great deal of vessel effusion happening, bone marrow infarction, necrosis, and a hyperinflammatory state, which might lead to worse outcomes, I guess.
And again, in relation to that study, that there was this high instance of neurological events. Do you think that might also be explained by fat embolism syndrome? And in the paediatric experience, do you recognise that as a pattern, or is it rare for there to be concomitant neurological events?
So it's very interesting you should say this, because we have been discussing this recently. So now, I mean, over the last, let's say, 10 years or maybe 15 years, with the advent of more rigorous transcranial Doppler monitoring, we don't see the more traditional neurovascular disease leading to strokes. The strokes we see nowadays are exactly this kind of strokes, where they're associated with an additional acute event that leads to a sudden abnormality in the cerebral vasculature, which then leads to a stroke event. And often these children end up, when you investigate them, they don't tend to have MRA abnormalities. They don't tend to have, and they would have had normal transcranial Dopplers and then end up with a massive stroke because they have associated concomitant acute chest syndrome. Now, when you're treating a child for acute chest syndrome, you might be doing an emergency exchange transfusion, which can precipitate an acute a neurological event. You might be giving them corticosteroids, which might precipitate an acute neurological event. And of course, acute anemia can cause, great deal of abnormality in the vascular, in the cerebral vascular flow, and that can cause acute neurological event. So the answer is, yes, we do see increasingly a lot more of these atypical strokes, and some of them are associated with acute chest syndrome. And in terms of treatment, what we tend to do, obviously, apart from doing the usual exchange transfusion and neurological support, we tend not to continue them on long-term transfusion support because, I mean, obviously there's no vasculopathy, so you're not really treating vasculopathy, if you like.
Thank you. There's a question from Musin Al-Musawi. If not, we'll come back to Musin. Olyu Wilkie.
Hi, thank you, Subarna, for the lovely presentation and the overview. My question is, at King's, when is the earliest time you start hydroxycarbamide on children? Because some papers say 9 months. I'm kind of reluctant to start it that early, and as would say, a lot of our parents are also very reluctant to start it that early? And generally, I think they're more receptive probably around the age of 2. I just want to know from your experience.
Yeah, I mean, it's a good question. We tend not to start very early, to be honest. I mean, absolutely asymptomatic 9-month-old baby, we haven't really been offering them hydroxyurea. I mean, we talk about hydroxyurea at every clinic visit. So we've normalized hydroxyurea. We have normalized the fact that this is something which is part of your child's treatment. And we have had some patients who have asked for it at the age of 9 months, and we've kind of said, let them become 1 and then we'll start, that kind of thing. But I think like you, I think we've tended to start between 18 months and 2 years.
My other question is, in terms of fertility, I think that's really the usual problem that we get about the reluctance is always about male fertility, and I don't know how you tackle that, even though we say that there are lots of studies that show that this isn't necessarily a problem, but they still decide not to. So that's one of the barriers, I would say. Yeah,
I mean, I agree. I think increasingly with all the new work that's come through the French data, etc., you know, there is really, I mean, we are in fact now thinking that even with the adolescents, if they were to start hydroxyurea, we are not really in a position to offer sperm cryopreservation because, you know, at the moment it's only funded. I'll be interested to hear what others do with their patients. At the moment it's only funded for 5 years. If you're 17 and you sperm cryo, at 22 you wouldn't want to be using your sperm, and then you're going to have to pay for it every year. And you know, the information that we now have from all those studies, the French study published in Blood, etc., we know that, you know, if you discontinue hydroxyurea for a certain period of time, you know, the people who are destined to have normal sperm count will have normal. So there's always going to be some people who, as a result of sickle cell itself, will not have good sperm count. And what I tend to say to patients is that, look, there is that worry, but, you know, I can reassure you that, you know, we have loads of information now. I like you know, I say, yes, you know, the sperm count in acute, you know, whilst you're using it might be low, but it reverts to normal when you stop it. And I tend to say that, you know, even if you are not on hydroxyurea, there will be a subgroup of men who will not have any sperm just because they've, you know, their very severe disease has caused them to become azoospermic. So I think we just persist. I guess there's always going to be naysayers, but, you know, ultimately I think they come around, and there have been a few that don't, you know, and then ultimately when we are able to then speak to the person, the patient themselves, when they're a bit older, they do come back. I think we've just been very persistent, and we discuss it every time, and I think the reception is much better now. I don't know what your experiences, Olu, but our families that are with younger children tend to be a lot more receptive because I think we've started discussing it so much more now than we used to in the past.
I agree, having normalized it a lot more, we have a lot more patients on it. And now I think it's a lot more work for us generally, for the nurses, yes. Now that we've gone from like 150% from where we were before in terms of the numbers of patients. So yes, it's the uptake is a lot better.
Yes, yeah, and we, you know, our service has become an outpatient service pretty much, you know.
Siobhan, do you think we can draw any inferences about the relative effectiveness of transfusion versus hydroxyurea in preventing acute chest syndrome?
I mean, you know, I don't know the answer to that, but I mean, obviously the STOP study showed both. You know, when they looked at the secondary outcomes, people who were on transfusions ended up with far fewer episodes of acute chest syndrome, and the MSH study showed that far fewer incidents of acute chest syndrome. So I don't know whether, I'm not aware that there has been ever and there's ever going to be a head-to-head. But there are some, I mean, you know, what I've tended to do, and I'm sure all of you do the same, is if there are some patients who just will not take hydroxyurea. I find the teenagers sometimes or they may, there's a very, very, very tiny minority of patients who might be very sensitive to hydroxyurea. And sometimes just when we put them on transfusions, you don't see them ever again. They just come to day unit to have their transfusions and go home. So, I think it's either both is good. I don't know which one's better. But I guess hydroxyurea is so much better to use in the sense of, so less, in terms of what's needed. You just, and increasingly, I think we are getting a little bit more, relaxing a little bit more in terms of the monitoring, particularly with the information that's come from the African studies. So during COVID, we've only done twice a year monitoring. We've not seen any neutropenias that we hadn't predicted. We have, we are moving towards, previous, now when we, up to 25 milligrams per kilogram, we don't even, we're starting at 25 milligrams per kilogram increasingly now rather than 20. And we are not really doing the post 2 weeks, apart from the very first time, we're not doing post 2 weeks if we're increasing the dose. So we're kind of getting a little bit more used to becoming a little bit more relaxed about hydroxyurea. So I think the burden of care, health care is so much less for the families if we are using hydroxyurea. So if you were to compare, I obviously think the hydroxyurea would be a preferable option, I guess.
Yeah. Olu, is that an old hand or a new hand?
No, it's a new hand. Sorry, nobody else is asking questions. I feel I'm the only person asking questions. It would be really wonderful for us to have a new guideline for, particularly from your experience, because at the moment we're doing ours every 3 months. So one of my questions, are you trying to maximize the dose? Do you go up to 30 to 35 milligrams on all your patients? Are there also patients that hydroxyurea hasn't worked for? And I know we didn't talk about the use of hydroxyurea in the Twitch study for patients that basically have high TCDs and we're stopping transfusions with a crossover time, because we've had quite a number of patients who have been on hydroxycarbamide and their TCDs have been normal when they've been on transfusion, and when they've gone on hydroxycarbamide, they literally either go to conditional or actually they've gone really high again, and we've had to put them back on transfusion. So I just wonder, we had 2 or 3 patients like that. Can you just talk about your experience with that and the use of hydroxycarbamide with high TCDs?
Yeah, so with the Twitch experience, we find about 50% of our patients need to go back onto transfusions. And that is usually because they've had normal transcranial doctors on transfusions, and the transcranial doctors worsen when they're on hydroxyurea. We do Twitch patients if they have abnormal transcranial Dopplers, because that was included in the study, the Twitch study, and we also Twitch patients if they have mild cerebral vasculopathy. So the moderate and severe cerebral vasculopathy, we kind of classified it ourselves. We did, obviously there is no definition of what's mild, moderate, and severe, but we do monitor these patients very carefully. All our Twitch patients have 3 monthly transcranial Dopplers, and we really don't know when to stop that. So they are all still, so many years down the line, still having 3 monthly transcranial Dopplers. So those are the patients we definitely keep them maximum tolerated dose. They definitely need 3 monthly follow-up. So these are the ones that would come through on that. With starting at maximum or starting high and attempting maximum tolerated dose, we're increasingly trying to do that. We start at a higher levels. I've been, especially from last year's New England paper, where the Russell Ware paper, where they've clearly showed that higher MTD dosing is way better than otherwise, minimally effective dosing. So we are attempting, even in the non-neurovascular disease patient cohort, to give MTD. It's hard though, isn't it? It's, as you say, it's so much harder work to, especially in the context of younger patients putting on weight. And that's the other thing, if they don't come for assessments, you don't see them, and before you know it, 6 months has gone on, and they've gained 5 kilograms, and they've gone from 27 milligrams per kilogram to 22 milligrams per kilogram before you know it. And so in pediatrics, I think it's particularly challenging in terms of the practicalities, and particularly if you have, but as we have in London, large cohorts of patients that needs constant thinking about. And in terms of, what was the other question? Yes, in terms of transcranial Doppler and hydroxyurea, we, as is standard practice, we start hydroxyurea in conditional Doppler patients. So we don't, we would 100% start hydroxyurea in patients who have conditional Dopplers. It is very rare nowadays to see a patient who has had a previous TCD, which is plumb normal, and the next TCD a year down the line, which is greater than 200 centimeters per second. It's very rare to see that. I have seen a few, and usually they're the first TCDs. So we had a few patients on their year 2, age 2, first transcranial Doppler. You have an abnormal one, and you obviously have to transfuse them. But I think we are now increasingly catching them early, because I feel obviously that there is a continuum. So you start with the normal, then it goes up to conditional, then it goes to abnormal. And if we catch them at the sort of low conditional, high conditional, we don't even wait for it to be high conditional. When it's low conditional, that's enough kind of, ammunition for us to say, well, it's got to be hydroxyurea, I'm afraid. Vitamin H, as we like to call it.
I suppose because a lot of them will be on hydroxycarbamide anyway, now we probably won't even be seeing many high or conditional TCDs. Well, we're hoping anyway, the screening program really works.
There's a question in the chat from Asad Lukmani about crizanlizumab and how that might alter the options in terms of preventive therapies.
The original study, the one, the crizanlizumab study, they didn't see there weren't any patients with acute chest syndrome, was there? So I don't think they were able to tell whether, in both the placebo group and the treatment group. So, and there were only a very few patients. They were only followed up for a very short period of time. It's very difficult to say. This year's ASH had some real world data on crizanlizumab in the American context, because they've been using it for way longer than we have. But I'm not sure even they were able to show that just the follow-up's not been long enough. But one would imagine that if you give a P-selectin inhibitor, you'd imagine that would somewhat be salutary to the whole pathophysiology of acute chest syndrome, and it would be preventive. But I'm not sure we know that yet.
Yes, in light of the fact most acute chest syndromes occur in the context of a vaso-occlusive crisis, you would hope that it would be. But I suppose more data will come from the managed access program as well in the UK, which will be collected systematically from now on.
Yes, by the NHR.
And then there's a comment on need to review the guidelines or update the guidelines, which I think. Yeah. Any other questions at all? Asad, did you want to add a question?
Yes, thanks, Subarna. It was just a follow up to that question I put in the chat, really, about the crizanlizumab. I think I was mainly referring to patients who refuse hydroxycarbamide but might be willing to accept crizanlizumab, and I've had a few, and I think it all relates mainly to the fertility issue that was mentioned earlier. That does seem to still be quite a large barrier in adults taking hydroxycarbamide as well, and I've had a few patients who would actually accept crizanlizumab over hydroxycarbamide. And these are obviously the kind of patients who probably have frequent vaso-occlusive crises, but may also have acute chest syndromes as well. And just wondering how comfortable we would feel about using crizanlizumab over hydroxycarbamide in that situation.
I think the licensing requirements now is I think you have to have failed hydroxyurea in order for you to qualify to receive, or have to have not failed hydroxyurea, but you have to be symptomatic whilst being on hydroxyurea, if I'm not mistaken. That's right, isn't it?
I think patients who refuse hydroxyurea may also be eligible?
It's probably not very clear. I think we had a conversation about this in the NHP meeting, didn't we? And I think you can, I mean, when people used to do the same thing, didn't they, with deferasirox versus deferoxamine, where you would give them for like 6 weeks or whatever, 4 weeks, and say, well, it's not being tolerated or whatever. So it's possible that we have to. I'm not entirely sure whether you can do that, but you can get around that quite easily. And I'm sure there will be people. And I mean, I'm looking at the 16 to 19-year-olds who really struggle with hydroxycarbamide for whatever reason, either not being able to take it regularly or whatever. You know, for them to come in and have a infusion. But having said that, you know, the Julie Cantor presented the real world kind of their experience on using crizanlizumab, and you know, there was quite a lot of attrition. Lots of people, like 30%, didn't continue, and some of them as less as kind of 2 infusions. So within 2 months, they've decided that it's not for them. And I think what was mentioned was quite interesting was that you know, it might be that people so far have received intravenous infusional therapy that has provided immediate relief to whatever symptoms it might be, whereas to have that expectation managed that crizanlizumab was not going to be an immediate you know, improvement is something that perhaps needs to be discussed more before you start. The other thing was that there were some infusion-related kind of events, toxicity events, and some pain-related events as a result of the infusion. And in fact, they had, I think she had, they had about 30 patients that she presented in ASH, and they had, I think, one person who withdrew as a result of an acute pain event precipitated following the first infusion, or first or second infusion, or whatever. But most of them, even though there were pain events, they continued. So yeah, it'd be interesting to see how well it's received, you know, as well.
Okay. So one question about, sorry, I just have to get back into the chat to read it. Development of AVN on hydroxycarbamide, which is a contentious issue, whether there's a causal relationship.
Yeah.
But whether you continue the hydroxycarbamide or switch to an alternative treatment modality.
We continue. In short answer, I guess, yeah.
And the theoretical concern is that if the hemoglobin level increases significantly on hydroxycarbamide, it might increase the risk of AVN. But I don't think there's any convincing evidence to support that, is there, Subarna?
No, I don't think there is. I mean, I know that certainly in the hemoglobin SC patients, there's always that risk that the hemoglobin will go. I've never seen anybody very high, you know, hemoglobin's high enough for us, you know, for the patient to have symptoms related to, you know, high hemoglobins and hyperviscosity and things like that, needing venisections. I think we've just now, this week or maybe last week, had one SC patient whose hemoglobin has gone up to 140 or something and has just had their first venesection, but that's been the first patient ever. It's possible that we are not, either patients are not saying that they're getting symptoms, I don't know, but we don't, I mean, yeah, as you say, the evidence is not strong. We wouldn't necessarily, advent of acute of AVN episode will not make us stop the hydroxyurea, certainly.
Thank you. Well, if there are no further questions.
Can I just comment on that? I would say that Paul Telfer had a couple of patients. I think he did a series of patients that developed AVN. I think not long after starting hydroxycarbamide. I think he's got a series of patients. So it was just maybe, well, maybe they're not coincidences or just, but there were, he did a series of it. So I think he's got a paper on it as well, that there are also patients that have developed, but their hemoglobins were not necessarily very high. I think it was probably the hemoglobin Fs were quite high. I know there was a paper on that.
Thank you. So if there are no further questions, Subarna, it just remains for me to thank you again so much for speaking to us today, and we look forward to inviting you back in the future
Thank you for having me. It was a real pleasure.
Thank you very much.
Thank you.